This video is to present a suggested sequence for utilizing the COREX device in a core decompression procedure for femoral head avascular necrosis. The sterile COREX device will come packaged in a peel pack, single-use patient sterile form. When it's pulled out of the peel pack, there's a sharp trocar tip which will have a protective cap over it. We're going to remove that using this plastic removal tool, and I'm just going to push it off for you here. Take the trocar tip and the removal tool and pass that off onto the Scrub Tech back table. The device, as you've experienced from your demo kit, has two positions. The black on green, which is the open coring position, and then fully rotated black on red, which is the capture position for the bone graft. I'm going to put it back into the full green position and leave it there. At this point, we're going to take a drill-tipped guide pin and approach the... we want to offer as a suggestion that you initiate your lateral cortical breach closer to the greater trochanter than you might if you were to go perfectly along the central axis of the femoral neck. And there's a few reasons for that, but one of which is we're creating our cortical defect closer to the greater trochanter, where it's less likely to substantially weaken the mechanical strength of the bone. And the other is we've effectively shortened the distance that the COREX device has to reach to get up into the femoral head, which gives us more room for the lateral portion of the thigh so that it doesn't interfere with our handle on the COREX device. So once we've placed our guide pin maybe a finger breadth below the prominence, lateral prominence of the greater trochanter, and we've advanced it through the femoral head so you can see its position. We're then going to take, I think I'm ready.
Okay.
All right, so now we've got a 10 millimeter cannulated reamer. We're going to advance that through the cortex only. We want to go fully through the cortex, but not much further. Okay, once I feel that loss of cortical resistance, I'm stopping. And now I'm going to remove the cannulated reamer and leave the guide pin in. At this point, I take the COREX device. It's in the open harvest position, green on black, and we're going to advance it over the guide pin into our cortical defect. At this point, we're going to, under fluoroscopic control, advance the COREX device over the guide pin, making sure we're not pushing the guide pin until we reach the subchondral segment of the femoral head, or when the pin becomes available to us. I have to support this because it's a pretty dense interior bone, or foam, I should say, in this instance. Okay, at this point I'm going to stop. You can see my depth, or it's about 8 centimeters, and the COREX is going to be confirmed on a fluoroscopic study, both AP and lateral, to be in the proper position. I'm now going to go from, tell me when you are going to start again. Okay, so you can see the pin is available for us to pull out at this point in time. So you can remove the pin with a pair of pliers or a hemostat. Now we know that we would be able to determine on fluoroscopy the depth at which the tree find is up into the bone, but I'm just going to show you that we're all the way up into the femoral head just below the subchondral plate. And at this point I'm going to, and there's still enough room for most patients that we have distance for between the femur and the skin. We're now going to capture the cord bone by going from green to red, and we're going to extract it by rotating it clockwise or back and forth and holding it by the distal handle, and we're going to pull it out. At this point, you can see through the windows that we've captured a core of bone. I'm going to now go from black on red to black on green, and in a medicine cup and perhaps on a Mayo stand or back table, I'm going to extrude the bone. You can see some of the imperfections in the core from the guide pin. At this point, we can remove the portion of the bone that we want to send off for biopsy from the femoral head, depending upon how much you think needs to be sent. We can then take that bone and invert it so that the lateral portion of the bone is now medial. I'm going to advance it through the back of the COREX all the way to the tip. You can see it's right there at the tip. Again, with black on green, we're going to now put the bone. This bone should be from basically the greater trochanter and lateral aspect of the femoral neck. I'm going to advance the device back up all the way. I'm going to turn it over simply because I'm a little more effective with my right-handed pushing. Again, we're black on green. We're going to advance it all the way up to the subchondral region. At this point, we can back it out a centimeter or two and use our extrusion instrument to push that bone up into the femoral head. And you're going to feel considerable resistance. You might want to back it out a little bit further. Again, extrude, resistance, pull back a little bit further. And now all that bone has been extruded up distal into the very medial portion of the femoral head. At this point, there's no bone left in our COREX device. We can insert it on different angles up into the, again, black on green, up into the greater trochanter to harvest bone, capture, pull it out. You'll see we have some bone through the window or fenestration. You see we have bone. We can now put it back in the black on green, go on a different angle, harvest some more bone. Again, capture. I'm pulling it out to show you. Now we've added some more bone to our COREX, and that's basically it. There are some variants on this. We could go on several angles up into the femoral head to core out, if you will, the entire lesion, and then again fill it in with bone. So, you know, these are just suggestions. There's obviously different ways that you can use the device. But I think it's important, as was suggested earlier, to start your lateral cortical defect closer to the greater trochanter so that you have more of the instrument to deliver into the femoral neck and head and have more room for your soft tissue laterally.